for some of the tools we develop here. And of course, as a university, generally speaking, in every industry now, data and data analytics is important. And so at the university, we do research and we write papers, and our students write their dissertations on data quality related matters. So that's why, Yili is writing a PhD proposal, and it's going to be a part of her thesis. So the research is approved by the university. So we have an IRB approval. But just to let everybody know that we can definitely skip some questions in case you don't feel comfortable answering. We don't expect that to happen. This is not a child psychology survey, but definitely, we can stop the interview if you wish. So I think you had a list of questions earlier. Maybe you had a chance to look, but I'll let Yili start asking questions. And this is semi-structured interview. Please feel free to deviate or even ask us questions if you wish. And so let's get started.
Mm-hmm. Hi, Eric. Thank you for accepting this interview. From the start, can you describe your role in MDH and how it is related to health data?
My role is health policy analyst.
Mm-hmm.
I manage multiple special projects and budgets for Maryland Medicaid long-term services and supports.
Mm-hmm.
That's the long-term services and supports is the name of the administration that I work for specifically.
Mm-hmm. Okay. Yeah, great. So in our research, we have a new term called data defects. It refers to a discrepancy between the actual and expected correct values for data item. So can you give us an example of data defect from your context and daily work?
I was reading through the questions. I don't work specifically with data defects.
Mm-hmm.
So some of these questions I will not be able to answer.
Mm-hmm. Problems
that come up for me. A lot of what I do is trending, projections, policy analysis of why they're doing having this trend, what to do about it, and then setting budgets based on everything. I think some of the problems I have arise from either not capturing all of the data that we need within a system, and then if we do capture it, having it readily available. In multiple cases, it's not readily available for our use.
Mm-hmm.
And really how the data is stored is the most crucial aspect of having that information.
Mm-hmm.
So I don't necessarily work with data defects in the sense of data entry issues or that as much as I do in the other sense of when everything is aggregated and sent back to me.
Mm-hmm.
There may be some pieces either missing or it's not timely. Or there's so much data over different data is available in too many different formats that it's hard to pull it all together. For instance, we have multiple systems from our MMIS system, which captures all Medicaid eligibility information and provider information, billing information, to our LTSS system, which captures a lot of service information, specific program eligibility information, medical, clinical information, to comparing that also to federal data from CMS, the Centers for Medicaid, and Medicare Services, their data and their availability of data, with census data, etc. My biggest problems come from having 5, 10 different sources and be able to pull them all together and make sense out of more of a macro trend. So I do apologize. As I read through the questions, I think a lot of them have to do with specific things in our MMIS, which I may not have as many answers for.
Well, yeah, thanks for the answer. So sometimes you may think that it is not related, but I think some of the aspects of data quality you mentioned were not actually mentioned by the other people we interviewed, and that's why we interview people who have different roles. For example, you mentioned the availability of the data, the format of the data, and the problems that this can create. So this was not mentioned earlier. So similar to, for example, when we think about healthcare quality in a system or even in a country, accessibility is important, right? So access to care. So now we talk about data quality, so access to data, which was not mentioned by other people earlier.
Yeah, absolutely. That's one of the two answers. That was one is the daily aspect of patient care, having access to data across systems is one thing. The thing that I which is important. That's one of the issues I think with healthcare in general is having access to information across providers, across payers, etc. My area ends up being having problems comparing trends across different data sets, which we really need to get a sense of more of a macro level of healthcare. It's hard to do that when CMS, federal government, doesn't publish, doesn't collect the same information and give it out in the same time frames. I think we're dealing with time frames that are several years old from CMS, and it's hard to trend current data if all the data we have is our own.
So because of the policy changes, there are also changes in expectations and then even the data formats.
Yeah, absolutely. One of the things Maryland has done for the clinical side is we've tried to match up our clinical information, our clinical assessments for our residents in nurse facilities and in home and community-based programs for long-term care. We've tried to match up our assessments with what's done at the federal level. So when we end up looking at clinical information, health status, diagnoses, medications, etc., we will have similar data sets and similar data answers, not just the general topic, but the actual specific question that matches both at the state level and the federal level. And that ideally allows us to track a person across different payers, both Medicaid and Medicare. So having a discrepancy between the data you're collecting and someone else is collecting for the same person becomes difficult to really predict the future or to identify where there are problems and where there are not problems.
So in these systems, do they comply with some of the data standards or interoperability standards? And my question is, this happens even after people try to, for example, comply as much as they can, vendors and those who enter data. Go ahead.
There are... Well, let's see. Well, the ones I'm talking about specifically, I'm talking about approximately 30,000 people in Maryland that are, this is my area of expertise, would be long-term care, nurse facilities, and home and community-based programs. There's about 30,000 or so people. And there are clinical assessments that are required by the federal government to be done in nursing facilities. What Maryland has done, what Maryland Medicaid has done, is adopted a similar assessment tool in order to be able to compare like data across Medicare and Medicaid. So there's no federal requirement that. We participated in a program several years ago that offered money to states that wanted to improve data quality, data collection by implementing core sets of questions that kind of matched what the federal government was collecting. Some states participated. I forget how many. Imagine maybe about 10 to 15 states that are participating in that, and they will have similar data across this population. But not all states were required to do that. It kind of was an opt-in situation, and Maryland felt it was necessary in order to collect data and trend over time and predict years out of what populations were doing and how they were receiving services, what they looked like. It was important to do that. So there's no federal requirement. Maryland decided to move forward with that. I'm not familiar with some of the other assessments that are required or information that's required for the acute care and the managed care organizations. In Maryland, I know that covers a much larger population. That covers 1 million people. My population is smaller but more costly.
So as much as I can understand, so there are different assessment tools and even different software systems, even if they can use data standards such as ICD-9 or ICD-10, there are still problems of mismatch. Am I correct?
Yes. Yeah.
Okay. So in parentheses, actually, I did some work in home and community-based care, but mostly on the Medicare side, looking at the home health agencies, basically information technology adoption. So it's nice to hear about some people doing similar research on the Medicaid side, right? Or work on the Medicaid side.
Yeah, absolutely. This is actually something I'm working currently with UMBC, Ian Stockwell and Stephanie Cannon-Jones about doing trending of the information I'm talking to you about right now. And one of our pushes that we'd like to see more of is more comparison between MDS data, minimum data set data that's in nursing facilities, our data, which is based on a similar assessment, as well as census data about the population in general, where that's moving, and aging of the population. So if you had any additional questions about that, we're working on developing a full kind of analysis and what we call a chart book of trending for the past 5 to 10 years and backwards, and then 5 to 10 years going forwards. So that's one of the pushes that we're doing right now. And one of the areas of I think probably talk to Ian Stockwell more about it. One of his areas of not as concern, but the part that takes the longest would be trying to compare census data, MDS data, and our data. The census data, federal CMS data, and our data to really get at the full trend of our populations.
Yeah, so Ian will be in one of our PhD students' dissertation committee. I think I should be seeing him in 3 weeks, and I'll definitely bring that up.
Yeah, he's familiar with all of this stuff. So I just had a meeting with him last week at Hilltop about this.
He's familiar. So that student is doing some data, the identification research, and we included Ian as well. So it's I think there's a lot of related work going on at UMBC with the so for the home care we look at for example incorporating census data and such things like, for example, median income, some of the other demographics to do better predictions. So going back to this mismatches, how do you know about them? So it basically pops up as a problem in the field as you try to analyze data, or are they already well known and well documented?
Which type of mismatch?
So, for example, you talked about some formatting issues, some of the data mismatches because of different, data assessment tools. Are they pretty standard, or do you encounter them differently each time you deal with data to make policy decisions?
For MMIS information, the ICD-10, that stuff, I don't have as much input on that. I believe that it's a more centralized system that works across states. For data that's specific to my populations, it's how you ask certain clinical questions. So it's not just the diagnosis, but if you're asking about behaviors, cognition, if you're asking about
activities of
your activities of daily living, it's how you ask those questions that will. And if you ask those questions, if you get different responses, how do you compare the two? So one thing that one thing that we deal with is having a nurse in a nursing facility ask questions on an assessment, and having a nurse in a community type program ask similar questions, and making sure that we have the same kind of inter-rater reliability between asking the similar questions, getting similar answers. That helps us ensure that a decision we make to approve someone for services or care in one setting is applicable in another.
Okay, well, I think this is very interesting, because now when we talk about what we mentioned earlier, data defect, this is pretty observable to us. I mean, it's kind of obviously wrong, but you bring up this inter-rater reliability, so some of the problems with data can be even more subtle, right? Because different people are rating it, and so maybe we can call it basically reliability. So seemingly data may be okay format-wise, it may even fall in a certain range, but it may still not be correct, reliable, right? So I think it's definitely bringing up.
You can't end up relying on the training of the individuals that are doing those assessments. And for clinical stuff, it's difficult because you may have different opinions about training, or may have trained differently. It's a little different for, I guess, something more specific like an ICD-10 code, or something else, some sort of diagnosis that's a little more clear cut. But yeah, that's one of the aspects that for an everyday purpose of approving eligibility for people, knowing whether or not the person that did the assessment did it well, or is the same as somebody else, is an important aspect that's sometimes missing. So the key there is consistent training across users.
So do you think MDH should do something to address some of the data mismatch or data formatting issues that can affect your trend analysis at all? What's your opinion about that? Should there be any kind of focused approach to make data more useful to you?
I think we've done a few things. I think the very first one was making sure that the questions being asked in both across all these settings is similar, if not the same. Okay. I think, and we've done that in many cases. Again, I'm not familiar with managed care or the acute care settings, but for long-term care, that is something that we've done. We do. Since the tools that we use, the clinical tools we use, are very similar, we do not control the training of clinical workers in nursing facilities, but we do provide training to all of our assessors and anyone that works with a person. We train them here at the department, and then for the assessors, clinical stuff, we do have an annual web-based testing that happens. consistent. But we don't have, since we don't authorize all of our, since we don't have a centralized method of training and approving everyone that goes out and does these assessments. You do have some variability in how people may answer those questions. Generally speaking, it's not that big of a problem, but it is from a day-to-day aspect of eligibility, it does become a factor. Especially when it comes down to actually providing services. Since the people in our programs cost anywhere from $20,000 a year to $80,000 a year, and the number of services they get is sometimes dependent on the person that's can be dependent on the person that's actually trying to get them services, doing the assessments, etc. So it's that type of oversight and that training is important for us, and we do some, but like I said, it's not possible for us to centralize the training of everybody. So that's one area that we do not have the ability to do.
Yeah. So among the things that probably you could do, some prioritization would be a good idea, because. So then, connected to it, like, what are the most costly or time-consuming problems that you see that cost to MDH?
Time-consuming. We end up in. Again, it goes back to day-to-day things. Like we have denied someone for a service, or denied someone for a program, based on the information that we have. It's either a doctor's notes, it's our assessment, it's the doctor's notes, it's nurses' notes, it's recommendations from other clinicians. We've denied someone for that service, but they've appealed that information. If we don't have good documentation going in, we may end up denying someone falsely. And then we have to go to a hearing, and that becomes time consuming because we end up spending legal and clinical hours not making decisions and not doing actual patient work, but going to a hearing and defending our original decision. I think that ends up being the time consuming aspect of healthcare just in general, is that you end up making a decision to approve or deny something. And this does go across all aspects, acute care, managed care, and long-term care. You end up making a decision based on information that's been written down by a clinician. And that decision is based on the best information we have at the time. And if it's not accurate, we end up in a legal in a legal setting where we actually have to defend our decision or overturn our decision. That ends up being a time-consuming aspect of it.
Does it happen frequently or infrequently? Do you have any idea about the volume?
It depends on. I can't give you a good number, because the only number I can give you is based on my long-term care experience. There are, for our one program, of the 30,000 people I mentioned earlier in the long-term care kind of settings, we end up having several hundred appeals and hearings each year.
Okay. So
I would say up to about 1,000 or so things that we have denied, either a service or a program for, and we end up going to an appeal for. So that's information that, and there's quite a few of them are hearings that we would not have gone to if we had better clinical information prior to the hearing.
So I'm guessing
that's one aspect of it.
Yeah. So do you think there's also another side when you approve a program, maybe it may not be needed, like waste of?
Yeah, absolutely. That's the other end. It's hard. We do an analysis of ones that if we do an oversight of ones that we have approved, just to confirm that they are accurate. So we do some of that, but you're absolutely right. There are definitely people that, based on an assessment, was approved based on what's on paper, but may not need that service in reality.
Okay.
I think it's less often now, but it certainly happens.
So how about the abuse and fraud? Do you think they could be less if you had better data?
A lot of it comes down to training and oversight of the providers themselves. Because, I mean, you're absolutely right. There's definitely some fraud and some abuse of our programs just by either a specific provider that has answered questions in a way that they know will get them services.
I worked with Jesse Song about the oversight of this. There is a ISA system in place in-home support assurance system, I think.
Yes,
so that's the telephone system. So yeah, it also generates some data.
In Jesse's area, you're absolutely right. They have it's slightly different there, in which they can call in from someone's house and then leave and come back at 3 hours later, call back in, and they never did any work, but they're billing us for it. So that definitely exists as well.
So yeah, we'll be talking with Jesse sometime next week, hopefully.
Yeah, he'll have that perspective as well for that.
So in terms of making things better, we discussed some of the training or trying to achieve similarity in clinical care, so people will be entering consistent data in a kind of consistent way. So you also mentioned the difficulty of training. So my question is, where is the low-hanging fruit that can be addressed and bring the highest return on investment to make data more useful to you?
Trying to think about what would be the first area to tackle for that. I think some of it would be to have more oversight on the assessment process, the training process, to ensure that how one person fills out the assessment matches somebody else filling out that same assessment at that same time period. We don't do that type of checking.
But is there a general understanding of what data items are across the organization or among the people that you work with? So everybody knows, basically refers to the same thing using the same name, or not?
Yeah, that actually is very, very true. We do a 2-day training for our assessments, and then do an annual web-based training and testing. So everyone that does the assessments should be answering the questions the same way. And they should be passing that test each year. Whether or not they're actually on the field doing it correctly for each person is slightly different. But while we've done a lot to ensure that we have some oversight, we don't do the kind of on an individual basis go out and check their work for them. And the other aspect of that is we can't compare their work or their knowledge to knowledge of a similar a clinician in a different setting. For instance, those people the nurses in a nursing facility have a similar a slightly different assessment than we do in the community. So we can't really compare the work being done by both of those two groups.
So if there was a similarity measure to identify similar nurses or sometimes even the services that they provide, even to similar patients, then maybe you could start to detect inconsistencies, right? So
that's an ideal. We don't really have the resources to do that level of.
I'm speculating about some research ideas for future PhD students.
Yeah, absolutely. And then for one of our programs, they receive assessments by the provider themselves. So they've been trained in the assessment, but the provider has a conflict essentially there. So eliminating conflicts from the person that's assessing to the person receiving services is important.
Oh, okay.
That's what I was going for. The conflict of interest of someone completing an assessment that may have a vested interest in whether or not the person receives services. And that goes back to your fraud and abuse question.
Yes. So I don't know whether you're familiar with survey type of research, but we throw in some questions that actually we would know the answer, or the response to that question should be actually consistent with another response given to another question. So we then, based on the results, data, we basically look at whether the survey was a reliable tool or, the data is reliable. So do you think those types of kind of interventions can be implemented to your work, and that way you would have a measure of reliability?
Yeah, it actually sounds like I'm not familiar with the clinical assessment we use to know if they've done something like that already. The two assessments I'm generally referring to in this part is the MDS, minimum data set, which is from CMS, that's the federal Medicare group, and then we use the INTER-RAI. It's based on the MDS. INTER-RAI is it's not necessarily a company, but it's a group of researchers at the University of Michigan, and they do data analysis and testing of data across all the states that use the INTER-RAI. I'm not sure what they've done to if they've added questions or if certain analyses they've done to make sure that that's done. Assessments are correct. I think if they have not, we'd be interested in doing something like that. That does we add questions in order to verify that other responses match.
And of course, you cannot have people who act like patients so that the assessments can be performed on them, and you can understand whether the nurse did the same, did the expected job or not.
Oh, that's true. Yeah.
So you mentioned other states, other organizations, and I'm sure you have some counterparts in other states doing maybe similar type of policy analysis work on LTSS. Do you know whether they suffer from same problems and what they do?
I don't. The only one outside of UMBC that we work with, and it's not frequent, is University of Michigan, and they do work on the INTER-RAI.
There was a number of years ago, I went to a conference called National Association of Health Data Organizations Conference, NADO, and I saw people from different states. There was another conference recently. Dave Wertheimer sent me the link for that. So there are some, I think, conferences where people who deal with data from different states come together and talk. I can find out the names if you're interested in.
Yeah, we worked with the people. We participated in a research study with University of Michigan a few years ago.
Mm-hmm.
We worked with Arkansas, Louisiana, Missouri, Michigan, and I believe Iowa about their use of a clinical assessment tool. A little different than what we're talking about here. They were more discussing how to implement. And use the tool. We're more talking about kind of my stuff is more bigger picture, trending and budgeting and stuff, and predicting the future of long-term care. But yeah, that was a previous work we've done to get at more specific clinical information and how to implement, how to train, how to use the data, what to use the data for. One thing we use data for is for budgeting purposes of individuals, which is unique, I think, to most states.
Okay, well, thank you very much for all the information. I think it is definitely gave us a different perspective, which is a high-level, perspective. So apparently, some of the very low-level data quality problems are not so important to you, but you do trend analysis, and you mentioned some of the very new and interesting things to us, at least in the scope of this research, such as like the reliability of the data, some of the formatting problems, and so thank you very much. Do you have any questions to us?
No, thank you for. I'm sorry I didn't get to go through all your questions for you, but I'm happy I was able to help.
So what I did is actually I was at the same time we were talking, I was keeping an eye on the questions, and based on your responses and experience, I modified them as we went through the interview.
Great.
So yeah, we would be happy to basically keep you updated about our results, and thank you very much. Do you have anything to add?
Thank you.
Well,
great. Thank you guys very much.
Bye-bye.
Bye.
Well, the kind of main exception is like people who are living in the same area,
Okay.
in the same building, because oftentimes, because our program is community settings based, like our goal is to get people into the community, but sometimes in like the place that the participant would call it their own home. It would be their home. But there's some people who abuse our program and try to just get people who don't really know each other living in the same, crowded in the same home area, and then say, "Oh, this is a community settings," but it is, like, clearly is not, because then the provider who does that will benefit from multiple sources of income, and it's kind of almost like they're churning out people in the same home. So that's been what we've been looking at is we've identified a couple people who live in like the same building, and the provider owns all these buildings. They're trying to collect these are homes that aren't that great.
Yeah.
They're like dingy homes, really, and sometimes they might not have like a lock and key. There's been cases where someone doesn't have access to the bathroom. It's kind of all terrible kind of things, but
yeah. One thing I learned from the project we did was like the type of data analysis you do, it requires a lot of insight. So it's not like somebody who can just come in and without learning about the domain, because you keep thinking about it and you have new observations, and then you keep analyzing data and find new things.
Yeah, that's definitely true. I think it's that's also been one of the challenges. It's like one of the challenges we've been doing is like we found like outliers in these different examples in the data, like we're anomalies in the data, but then oftentimes from there we have to commit someone to go out and investigate them, and And like, I think that disconnect between like the data as well as the policy unit and even the compliance, like the inspectors who go out into the fields, that's been also challenging for us. But we do have good news. We do have a recent case that we think is building up traction. So hopefully it'll lead somewhere. It can some people abroad.
Yeah. Well, that's what you should be doing. Okay. Well, thank you very much again, Jesse, and I hope to let you know more about our results in the future.
Okay. All right. So thank you.
It's very old, so it cannot. If we keep putting new information into the system, it cannot always keep up to date. So my boss says sometimes like we need to check if the system can handle it too much. They need to turn the data into a third party maybe. Yeah, I think that would cost money. Like if our system cannot do this task because the system is so old, they need to turn this business into a certain part of the tracking process. They need to turn it into a third party. Yeah, I think that may be the most costly part.
Yeah.
So if we cannot like completely upgrade a system and the current system cannot take the improvements, and then we have no way but to turn this part like into maybe another like a small business that they can like specialize in doing that. Yeah, I think that so in that way, if we can do it ourselves, we need to pay the like a third party vendor, I think.
Yeah.
Yeah, and that would cost a lot of money actually.
Then what are the communication or collaboration difficulties in data quality improvement activities? Can you give us some examples?
Yeah, I think because I work mostly as a data analyst, so I mostly only have like exposure to maybe just a few of my colleagues and also my boss. But like sometimes the data improvement decisions need to be made in a higher up level. So maybe my boss can make the decision, but we are the people actually working on the very specifics. And so I think that could be an issue. Yeah, because if I want to know something, I have to ask my boss, and then he doesn't know. He's not very sure, and he needs to ask like people above him. So then sometimes it may take very long time. Because please.
Is there any communication difficulties within your group?
You mean like horizontal? Like me and mine?
Yeah. If there is any.
Yeah, I think within a group is much more better. Yeah, but my boss is like my boss is also in our team, but like we have a hierarchy. Yeah. But like the people who's actually in the same level with me, I think I find it much more easier just to communicate with them, but much more difficult to get something to my boss, and then my boss needs to ask his boss. Yeah.
Okay. In data quality improvement, what current activities do you think can be possibly eliminated or merged?
Current activities?
Yeah, that you have to do each time, but there's not much necessary for that.
In terms of current activities that are unnecessary and can be eliminated,
Yes.
I think Yeah, I think just when we talk about like just for me, I will receive like requests from like other people in a building, and they will send this request, say, okay, maybe changes to this provider, and then so I think these providers, they all have like a very long provider name, and they have like other numbers that we can identify them. So each time I receive like a form or request, I need to manually type in of their name again, maybe just for records. So everything we do need to keep records. So I think that's kind of like a waste of time. And I need to, because the people who send me this form, they are typing from their computer like the name, their like provider name, their provider number, and they're like there's an even longer number called like NPI number. So to identify and their address, and then if this request is sent to me, my boss say like, because we are working in different teams, so my boss say I didn't want to keep a record of this request, so I need to type them again into my computer. We need to type into a Google Sheet. So my boss keep a Google Sheet. We keep records of all the requests that's sent to us. So I need to type in all of these, which I think that's kind of like repetitive. Yeah, if there was some way better that I can save typing all these like long requests. Yeah, like besides the provider's name and number, I also need to type in like what their request is, just so we can have a record. Yeah, I think that's kind of like if it can be eliminated, it will be very.
So when you try to find a provider on the change request, you have to type all the information. Am I correct?
Yeah, I think it's partially correct. I only need to type their provider number, but like to look for like the information of this provider. But like just because we're in different teams, so my boss will think, okay, I want to keep a record of everything other people send to our team. So he actually wants us to type in all of the like name, address, and also the request into a Google Sheet. So it's actually, I don't need all of this information to look for, to look something up. I also need to record all of the information. Yeah.
Are there other similar organizations you know with a better data quality improvement mechanisms?
Better data quality improvement mechanism. You mean like a better information system, or do you mean like their working process?
Yeah, I mean, when it's so when the process for them to improve their data quality.
I don't have it on the top of my head, but I think but just from what I remember, maybe like at school, but they don't have a lot of. I don't know, but I just don't understand. Maybe our team has a lot of like paper documents. Like each like person have a lot of paper documents in their cube in their office. So I don't know. I haven't really worked in other similar health organizations, but I don't know if they all have like volumes of paper documents. They need to keep record. Yeah, I think like if we have a information system, a digital system, why do we have so much like paper documents? Why like? Actually I don't know. Maybe I I haven't worked in very similar organizations. I don't know. But I would imagine that they will definitely be better mechanism.
Yeah, that's fine.
Is there any other questions that can answer better if you're looking back?
Yeah, I think.
Is it like what you're looking for? Because for me, like I only work as a data analyst. So these questions are kind of like abstract a little bit for me.
Yeah, so thank you very much. You gave us a lot of useful, detailed information. So we'll go over the basically recording and we'll transcribe it. So this is basically a process that we perform after each interview, and we'll analyze the data and keep you updated about the research results we have. Do you have any questions or comments for us?
Yeah, if you have any, like, you just email me. Yeah, definitely. Thank you.
Thank you.
Thank you.
Yeah.
Thank you.
Thanks for giving us time on Sunday. Bye-bye.
Definitely. Thank you.
Yeah,
Bye.
thank you.